Hey everybody, it's Patricia Coughlin, and I'm responding to a request by a subscriber to talk about the importance of case specificity, particularly in ISTDP. I mean, this is always important no matter what method you're using. I mean, how can you really treat someone in a very specific, tailored way if you haven't really assessed not just the nature, history, and severity of their presenting problems, but also assessing their character structure and their capacity to do therapeutic work. In ISTDP, and I think a lot of methods that have sort of a systematic nature to them and certain techniques that are valued and prioritized, there can be the tendency to just begin to intervene and use those methods without, again, really understanding why and when you would use them in a particular case. So this is something I've always been very attuned to and have been teaching about. In fact, even in my very first book from 1996, I illustrated this point by talking about three cases in which the presenting complaints were the same: anxiety, depression, and interpersonal difficulties. And yet, in inquiring and assessing their capacity to identify and experience feelings, to tolerate anxiety, watching where that was going, and the nature of the defenses that they were using, how tenacious and syntonic they were. Each of them were just as different as night and day. One was neurotic, single focus, otherwise, highly functional. The second one had a character disorder and therefore was using defenses in a rigid habitual way, which contributed to the depression. And then the third person was really quite fragile, and it turns out had an underlying psychotic process. So you can see why you can't just treat symptoms. You're treating a person, a specific person, with those problems. And again, there's a tendency for clinicians to assume that they know the underlying cause of symptoms. So another common thing, certainly in ISTDP, is to think that depression is inevitably the result of anger turned inward. And while that's certainly very often the case, it's not always the case. And that's why you have to do a detailed inquiry. When did this depression start? What was happening at this time? Depression can be the result of pathological mourning. And in fact, that was the case with someone who brought me a patient to look at. They had been treating this man for a year already, and assuming that the problem was anger turned inward and also guilt about the anger. And they kept going for, anger toward the mother and the father and whatever. And the guy was making no progress. And when I began to inquire, well, when did this depression start? And how do you know that that's the mechanism? It turns out that the clinician had never really done an inquiry. And so they went back and did that. And when the clinician returned, it turns out that this patient, who was about 55 at the time, had been highly functional all his life until 2.5 years ago. So even though she was thinking it had to do with all this anger toward her parents, well, if that had been the cause, why wasn't it troubling him for the first 53 years of his life, right? So it actually turns out that the depression only struck after the death of his father. And so you could say, well, maybe that's just pathological mourning, right? So you have to start again to really dig around, be like Columbo, start to ask questions. And it actually turned out that this fellow had been in competition with his father all his life and had much preferred his mother. And so when his father died, and he kind of got his wish to be rid of his competitor and to have his mother all to himself, he got depressed because there was a guilt and self-punitive factor there. Okay, so that's another case for being very specific. And then the other one I want to talk about briefly is how you have to track even the same person over time. So you're not going to be treating someone, interacting and intervening in the same way 10 sessions down the road as you were on day one. People change. These interventions can be extremely effective, and often clinicians don't realize they're not tracking. They're kind of treating the person they saw initially and not treating the person who's in front of them now. And I'm thinking about a particular case of a woman who was quite chaotic in many ways. If you looked at her symptoms and her history, substance abuse, suicide attempts, hospitalizations, she kind of fit the DSM criteria for borderline personality disorder. But again, what does that tell us? It told us that she had a very low capacity for tolerating anxiety about her intense mixed feelings, with a tendency to act out in such a way that would just create, again, more guilt and more bad feelings about herself, and then self-punishment. So the treatment was actually very effective right from the start. I was able to get really to the heart of the matter in the trial therapy, and she had significant effects really in the first 3-4 sessions, getting much, much better, feeling depression lifting, the compulsion to call unavailable boyfriends going away, being able to soothe herself and so on. And then like in the 4th session, I again started to intervene as I had in the previous 3 sessions because it was so effective. And yet she was in a different place. And so suddenly she started to say, cross her arms and say, I don't want to do this anymore. I mean, I don't want to just come in here and feel my anger and imagine killing everybody. I mean, how is that going to help me? I mean, obviously it has, but, and she just was really overtly resisting the process that I was trying to get going. And so initially I was just seeing this as resistance and treating it as such, but she kept digging in her heels. And suddenly I realized this is a woman who had been incredibly compliant all her life and was always going along with other people, saying yes when she meant no. So at first I realized, oh, wait a minute, she's saying no to me. This is actually a really good thing for her in this specific case. It wouldn't be in other cases, but it was for her. And then I also realized that at the same time that it was important that she could say no to me. So she's saying no to me, and then I said, okay, let's put you in the driver's seat. So instead of me running the show and her just responding, I said, let's look at what you want, what you would find helpful. And this ended up being an enormous breakthrough for her. She literally said, I don't think anyone's ever asked me that. What do I want? I mean, like, who the hell cares, right? So on the one hand, it was very corrective with me, but then she really internalized it. I mean, she came back the next session and she said, now every single time, somebody asks me to do something, I ask me, right? I say, Patricia, do I want to do that? Am I just going along? Am I serving myself up as on the platter, right? Or I'm being an honest presence and I'm taking care of myself. So that was huge. So again, being specific, where are you in the process, right? Who is this person sitting in front of you? They are likely not the same person that you saw 2 months ago. So I hope this gives you some motivation to be very, very case specific and to tailor your interventions to the current needs and capacities of each individual patient. So I hope this is helpful to you and look forward to your feedback.